Hello everyone. Today we will cover dermatology portion for Plab 2. So basically in dermatology you only have two symptoms. You either have lesion or rash. So any patient presenting in dermatology will either complain of a lesion or a rash. So we basically will discuss the history taking and the differentials and management for these two symptoms, and your dermatology portion will be covered. Okay. So now a pro tip for the dermatology portion is that in derma, you always have to tell the exact name of the diagnosis, okay? So for example, if there is a lesion on the patient's face and it feels like and you suspect that it is basal cell carcinoma or it feels like it is melanoma, so you will have to say that it looks like a type of, I'm suspecting a type of skin cancer, which is called as melanoma. Okay, or I'm suspecting a type of skin cancer which is called as basal cell carcinoma. So you have to tell the exact name of the diagnosis. You cannot, get away by saying that it seems like a type of skin cancer. So keep that in mind. Also, when you are done with the examination, when you verbalize your examination that I will take your vitals and I will examine the lesion, do describe the lesion to the patient. Okay, so tell them that maybe there is a small lesion, it's red, or the color, the size, the shape. So do describe it to the patient. All right, so these are the tips that can differentiate you from other candidates, and these small points will bring you more marks. Okay, so now let's discuss the lesion part of the dermatology. So when a patient presents with lesion and he says, the doctor, I have a lesion on my face, I have a lesion on my back, or anything. So you need to ask as many questions about the lesion as possible. Okay. You will examine the lesion later. They might show you a picture or something, but before that, you have to create a mental image of the lesion in your mind. So you will ask as many questions about the lesion as possible. Okay. So first of all, triple S, that is site, size, shape. Okay, so site, size, shape, color of the lesion, duration. Okay, when did you first notice it, and how has it changed during this time in terms of size, shape, or color? Okay, so site, size, shape, and color, and then the duration, and how has it changed in terms of size, shape, and color? Okay, then you will ask, is it with the skin or above the skin? Okay, so these are basically questions to create a mental image of the lesion in your mind. After this, you will ask about its symptoms. So is it painful? Is it itching? Is it bleeding? Is there any discharge there? So you will ask about the symptoms of the lesion. Okay, pain, itching, bleeding, discharge. After that, you will ask about the surrounding area of the lesion. So you will say, what about the surrounding area? What about other parts of the body? Are there any similar lesions on other parts of the body? And at the end, the red flag questions that you cannot miss is cancer symptoms. So fever, appetite loss, weight loss, lumps and bumps and nights, right? This is absolute must in case of lesion, because any lesion can be skin cancer. So you must ask the cancer symptoms. So it's basically asking about the site, size, shape, so triple S, and then the color, and then the duration, and how has it changed over this time, and then basically the symptoms of the lesion, so pain, itching, bleeding, discharge, and then the surrounding area of the lesion, other parts of the body, and cancer symptoms. So there is basically your history taking of the lesion, history of presenting illness. After that, past history, so previous occurrences of the lesion, and skin exposure and tanning. So you must ask the skin exposure and tanning, because skin exposure or tanning are a risk factor for many of the skin conditions. So this is also an absolute must question. Any previous skin exposure or tanning. Sorry, any previous sun exposure or tanning. So for example, any visit to a sunny area where the patient was exposed to sun for long times, or maybe the person is working in an occupation which is sun exposed. Okay, so again, medications is important, because in case of immunosuppressive medications like methotrexate, patient will have an increased risk of skin cancer. Okay, then allergies is important, because some of the skin conditions like allergy, like eczema, has a strong connection with allergies. All right, family history is very important, because there can be family history of skin cancer, there can be family history of eczema. So family history of skin conditions is also very important. And then occupational history is important because of the relation to sun exposure. Okay, so this was your history of presenting illness basically. So after completing your history, sorry, this was your total history. So after completing your history, you will ask about ideas, concerns, and expectations of the patient, and then you will proceed to the examination. So in examination, you will observe the vitals, do a head-to-toe examination, that is GPE, and then you will say that I will take a look at the lesion. And so the patient, because the patient, the simulator will not actually have this lesion, so they will show you a picture. Okay, so when you look at the picture, after that, you will thank the patient and say, thank you, I examined you and I saw the lesion, and you will describe the lesion, okay, for the patient. All right, so now let's discuss the each differential diagnosis of a lesion and its management. So first of all, mole. Okay, so in mole, so all of us have mole, and all of us know that it's basically a benign condition. So you will ask about the above history, but also you will ask why they want to remove it now, because basically mole is there for all of the person's life, okay, for a very, very long time, and it does not cause any symptoms. So why want to remove now? Okay, so assess the reason of them coming now, and see if it is affecting their mood. Okay, this is important because normally the NHS doesn't sponsor the cosmetic surgery, because removal of a mole which is not causing any symptom and it's totally for cosmetic purposes, NHS does not fund this procedure. But if it is affecting a person's mood and it is causing depression, then it qualifies for NHS funding. So you will have to assess the mood. Okay. All right, so how will you explain mole to the patient? You will tell the patient that it is only a harmless pigmented growth and it does not cause any symptom and it does not poses any risk. All right. Then regarding treatment, you will tell the patient that various treatment options are available. However, as the treatment is for cosmetic purposes, the NHS does not cover this, and you will have to go to a private clinic. But I'm happy to discuss different options with you. So different options include injections in the lesion. So basically steroid injections, which will require few sessions, and then the lesion will disappear, the mole will disappear. Then there can be laser removal, which might also require 1 or 2 sessions. Then there is an option of topical cream applications, but it require a long, long time. And then surgery. So surgery is the quickest option. It will remove the mole at once. But with surgery, it will leave the biggest scar, while topical cream will have the least scar. So topical cream takes the longest time but leaves the least scar. And surgery, you have the biggest amount of scar. So you'll tell all these things to the patient and let them decide whichever treatment option they want to go for. But you will tell them that the NHS does not fund cosmetic treatment. Okay. Yes, but you will safety net them that if they decide to leave it alone and not go for any treatment. So if it ever changes color, size, or shape, then please come back. Okay. Then basal cell carcinoma. So basal cell carcinoma basically it occur on the sun exposed part of the body, especially on the dorsum of the hand and on the face. Um, and it have pearly shiny appearance. Okay. um so, and it will be like the history will be long, so that will be there for maybe 3 or 4 months. So how will you explain it to the patient? You will tell the patient that you have basal cell carcinoma, which unfortunately is a type of skin cancer. However, it does spread very slowly. What will you do? You will inform your seniors, you will do routine blood test, and you will do routine referral to derma. Okay, please remember, in basal cell carcinoma, we have routine referral to derma because basal cell carcinoma spreads really very slowly and it rarely metastasize. Okay, so we will do routine blood test. We'll also do a swab to check for infection, and then we will arrange a routine referral to derma. But if the basal cell carcinoma is on the face, then 2 weeks urgent referral to derma. So for example, if the BCC lesion is on the dorsum of the hand, then routine referral. But if BCC lesion is on the face, then 2 weeks urgent referral to derma. I also show a picture of BCC to you. Somewhere here. Yeah. So it's a lesion like this with pearly shiny appearance, okay? And a history of sun exposure. When you ask about, history of sun exposure, you get a positive history. The next is squamous cell carcinoma. So this is basically squamous cell carcinoma, okay? I also recommend to search more pictures of the BCC and SCC on the Google so that you really get a good grip of being able to diagnose them by just looking at them, okay? Because you need to say the exact, the exact diagnosis. But even if you are not sure, you can just test skin cancer and it will get you some marks at least. All right. So in squamous cell carcinoma, you will do all of the above. You will inform your seniors. You will do routine blood test. You will arrange. You will do all the routine blood tests and a swab as well. And you will arrange an urgent 2-week referrals to derma. Of course, you will explain it to them what the dermatologist is going to do. So the dermatologist is basically going to examine them again, and they will take a sample from the lesion, which is basically biopsy, and examine the lesion under the microscope and to confirm the diagnosis. And they will plan the treatment accordingly. They might plan for surgical removal, mostly surgical removal. Okay. Now after this is melanoma. So in melanoma, you will tell them that I'm really sorry to tell you that you have a condition called melanoma, which is unfortunately a type of skin cancer. Again, all of the above, informing seniors, arranging urgent 2-week referral to derma, telling them what the dermatologist is going to do, and arranging a follow-up after they are seen by the dermatologist. So this is basically melanoma. Um, yeah, so this is basically melanoma. So if you can see, it is, it is a heterogeneous type of lesion with different colors in different area. It also have irregular borders. So this is basically melanoma. Okay, a simple mole will be smaller and it will not be flat. It will be raised and it will have a single homogeneous color. Okay, so this was basically melanoma, the most dangerous of the diagnosis here. And then the next one is seborrheic keratosis. Let me show you the picture first. Okay, seborrheic keratosis is basically what we call is a stuck on appearance. It has a stuck on appearance and it is basically a harmless growth. Let me look for the picture. Here's the picture. Okay, I'm not finding a picture at the moment. I will show you the picture at some point, but let's first discuss seborrheic keratosis. So it will tell the patient that it is basically a harmless skin growth and people tend to get them as they get older. Okay, so it's more common in old age and it's also related to the history of sun exposure, but it's harmless. But if patient has no personal or family history of skin cancers, the patient is very low risk patient and you will just reassure them, okay? But if the patient has either a personal history or a family history of skin cancer, then you will refer to the dermatologist just to be on the safe side, but it will be a routine referral, not an urgent 2-week referral, okay? And yeah, so in lifestyle advice, you will tell them to avoid any further sun damage and use sunscreen. But you will, as safety net, if you are sending the patient home, reassuring them, if it's a low risk patient, you will still safety net that if it changes in size, shape, or color, or grows rapidly, or it bleeds, or scabs, or become red or irritable, then please come back to the GP clinic. So basically, you will tell them that if changes in size, shape, or color, or it's causing any symptoms like bleeding or scabbing, then you need to come back to the GP clinic. Okay, guys, I think I forgot to put the picture of seborrheic keratosis, but you can just look it up on Google. It's really a very, once you look at it, you will never forget it. Okay, it's really have that pathognomonic appearance, stuck on appearance. But you should check the picture on Google because it's really crucial for you to come up with the diagnosis of seborrheic keratosis by looking up at the picture, because from history taking, you might not be able to come up with this diagnosis. Okay. Yeah, so the last one in lesions is basically syphilis. So syphilis will present as if in primary syphilis, the patient present to the dermatology department. So in case of primary syphilis, the patient have a lesion which is called gamma on their private parts. Okay, so they will tell you that I have a lesion on my private part. So we will take all of the above history, but as so you will get some clues about it being syphilis because in syphilis there is a lesion in the private parts, but it does not cause any symptoms. which is other lesions, for example, herpes simplex or the other rare conditions, they do cause symptoms. Like either the lesion causes pain, or there are enlarged lymph nodes, or there is burning of urination. But in syphilis, there are no symptoms. There is just a lesion on the private part, and when you look at the lesion, it is also really pathognomonic. Okay. So, and in case when you are taking sexual history, it will also be positive. They will not be practicing safe sex. Okay. So above history, but questions about neurosyphilis as well. So you will ask about any headache and any weakness in any part of the body. Okay. This is because there's difference in the treatment between primary syphilis and tertiary syphilis. Okay. So you will ask questions about neurosyphilis here, any headache, any weakness in any part of the body, but it's going to be primary syphilis just because primary syphilis presents to the dermatology department, neurosyphilis presents to the neurology department. Okay. But you still need to ask this question just to rule out neurosyphilis. You will also take sexual history here. So are you currently sexually active? Are you in a stable relationship? And do you practice safe sex? These are the questions that you need to ask. Okay, management here. You will tell the patient that I suspect that you have syphilis, which is a sexually transmitted bacterial infection. Okay. We will refer you to the genitourinary medicine clinic. Please don't say gum clinic. Okay. Don't use these abbreviations in exam. I wrote it here just for, for the sake of convenience for me, but you will say genitourinary medicine clinic. So you'll tell the patient we are going to refer you to the genitourinary medicine clinic. They might take a swab from the lesion and examine it under microscope and do some blood test. They will give you an injection of an antibiotic called penicillin. Most people require only one dose of the antibiotic, but at the same time, you will give advice to avoid any sexual activity for at least 2 weeks after the treatment finishes. Okay, so 2 weeks after the injection of the penicillin, it is important for you to inform your partner so that can get tested as well. And of course, if they are reluctant to inform their partner, then you can offer the partner notification program. So this was all about lesions in dermatology, and the next video is going to be on the rashes in dermatology, and that will conclude your dermatology for Plab 2. So I hope this was helpful, and I will see you soon with the next video.